session, which of course is hosted by the GI Foundation in association with Project IEcho, University of New Mexico. So as you know, these sessions are held weekly on a Wednesday. Please, the chat will be open for questions, so you can either post them, or even better, if you could put your hand up and interact with us directly. Okay, so we're going to have two presentations today on IBD mimics, a pragmatic approach. And these are from my colleagues from Zimbabwe, Leo and Tendai, who are also honorary South Africans because they spent quite a lot of time here with us in South Africa. So Tendai is going to speak first, and then it's going to be followed by Leo. And then after that, we will take some questions. So Tendai, if you want to start sharing your screen.
Thank you, Jill. Thank you for the introduction. I hope you can hear me.
Yes, we can hear you perfectly, but can't see any slides yet.
Right.
Yeah, perfect. Just needs to go on slideshow. Yeah, that's perfect.
All right. So good afternoon, colleagues, and welcome to this meeting. So yes, I'm a medical gastroenterologist and currently practicing in my home country in the capital city. And so today I will be talking about IBD mimics, and I will just probably restrict myself to the context of IBD mimics in the context of new onset IBD, because I'm sure we know very well that even in individuals with an established diagnosis of IBD, they can get, if you think they're having a flare, one still has to consider the possibility of a mimic. So I work at one of two tertiary hospitals in the capital city. This one is called Salim Gabe Hospital. And for a long time, it was actually known as Harare Central Hospital, but it experienced a recent name change in honor of a former first lady by the name of Salim Gabe. So she was the wife to the late Robert Mugabe. But Salim Gabe is also late, but she had did quite a bit of work at the hospital in terms of children's health. So I'm going to start my talk by showing these two position statements. These are echo position statements, and in this publication, which was titled The Clinical Pathological Spectrum and Differential Diagnosis for IBD. And position 26 says that the reliable distinction between IBD and its mimics requires a constant awareness by clinicians and pathologists of the wide range of differentials, and close communication is important. And position 28 actually says that distinction between IBD and its mimics requires a comprehensive clinical assessment, including a full history. It's important to establish the duration of symptoms, and investigations often include the whole array from simple blood tests, through endoscopy and imaging studies, sometimes to more complex tests. So I think this quite nicely summarizes what we are discussing today. So for us to talk about mimics, there has to be a reference point. So the question is, what is the diagnosis of IBD that can be mimicked by certain conditions? And I'm sure you've all heard of the statement that there's really no single diagnostic test for IBD. And most of you who have seen or managed IBD patients will know that sometimes the diagnosis can be quite challenging to establish. And because there's no gold standard, the diagnosis is really based on a combination of various characteristics, the patient's symptoms, laboratory tests, imaging, endoscopy, as well as histology. So with IBD, we know we want chronic symptoms, and often they're either progressive or they are relapsing or remitting. And we know that abdominal pain is a cardinal symptom for Crohn's disease, sometimes it's diarrhea, whilst rectal bleeding or bloody stool is a cardinal symptom for ulcerative colitis. We often want to demonstrate blood or stool-based inflammatory markers, particularly the stool-based one, because this is IBD, so it's an enterocolonic inflammatory process. And then we also can look at radiology or imaging, and that's useful because it gives us an anatomic pattern or distribution of the disease. But also importantly, we can diagnose complications that are often associated with IBD. And then endoscopy. But as you are aware, none of these features is actually specific for IBD. But I consider that endoscopy is actually probably the most specific, parameter when it comes to the diagnosis of IBD, because it allows us to look at the lesions and describe the lesion characteristics, as well as their distribution, and allow tissue sampling. So I think one of the challenges with the diagnosis of IBD, because of this, is that a lot of the times endoscopies are not done by people who have enough knowledge about IBD. So we often get patients referred because an endoscopist saw some ulcers in the colon and took some biopsies, and the patient is referred as a diagnosis of IBD. And then, of course, with histology, we want to demonstrate features for chronic inflammation. So I will say that, most cases of IBD are actually diagnosed correctly. However, there's a substantial subset which may be initially misdiagnosed, and we're going to just look at some evidence quickly in that regard. So this was a fairly old publication from the IBSEN cohort. The IBSEN is the inflammatory bowel disease in southeastern Norway. And in this article, which was published in 2006, they reported a change in diagnosis during the first 5 years after onset of IBD. And so what they did was look at 843 patients with a diagnosis of IBD within this registry. Some of them had fairly established diagnosis of UC or Crohn's disease, but there were others who had an indeterminate colitis, and those that had what they called possible IBD. And at re-evaluation of the diagnosis after 5 years, there was a change to a non-IBD diagnosis in about 6% of patients, with the highest proportion of change occurring in those who had an indeterminate colitis or possible IBD. So my apologies, it's not a very clear slide, but it's just a follow-up to what I've just reported. So in this same study, and we can just focus on the areas that I've highlighted here, where of the 40 patients who had initially an indeterminate colitis, nine changed to a non-IBD diagnosis, which was roughly 25%. And among those who had a possible IBD diagnosis of 64, 32 changed to a non-IBD diagnosis, which was about 50%. So this was another study, a hospital-based Korean study, which receives patients that are referred with a diagnosis of UC or Crohn's disease. And they followed up these patients for just over a year, after which among the patients with a UC diagnosis, about 7.5% were changed to a non-IBD diagnosis. And of those that had a diagnosis of Crohn's, 12.7% were changed to a non-IBD diagnosis. So the Inflammatory Bowel Disease Live Interinstitutional and Interdisciplinary Video Conference Education, which is abbreviated IBD Live, is a tele-video conference platform that brings together, IBD specialists from all over the world, and they meet roughly weekly, where they discuss, complex IBD patients in terms of whether it's a diagnostic issue or a management issue. So it's a platform that's been running since about 2009 to date. And in the next study that I'm going to just talk about, it was a publication that was actually based on a review of some of the cases that were discussed in this conference or series. So it was titled The Clinical Decision Making in IBD Mimics. So they were looking at some of the cases that had been discussed and how much of those were considered to be IBD mimics rather than established IBD diagnosis. So they reviewed 371 cases between May of 2018 and February of 2023. And what they found was, of those 371 cases, which represented 186 hours of live IBD live recordings, 306 cases were IBD, but there were 65 cases that were considered IBD mimics, and that that was about a 17.5% IBD mimic rate. And this is the outline of the different cases of the mimics, where you see that most of them were systemic diseases, including vasculitis, as well as medication-induced. And in terms of medication-induced, the immune checkpoint inhibitor, colitis, was top of the list. And it's something that's actually probably widely or more commonly available in that part of the world, in the Western world. The other thing that they found was about 38.5% of the patients who eventually turned out to be a mimic were actually treated with biologics. Now, this might not be an issue if most of your IBD mimics are otherwise inflammatory conditions, but I imagine, or I think most of us will agree that most of our mimics are probably infectious diseases. So it might be an issue if we are going to treat infectious disease patients with biologics. They also looked at what extra evaluation was conducted in order to establish a correct diagnosis of a mimic. And in this representation, 21% of patients, which was the greatest number, they just needed additional endoscopic biopsies. And we see that a lot. Patients who come in, your initial diagnostic workup is not really compatible, and you often have to go back and do the endoscopy and get more biopsies. So that's a useful thing to remember. 17% of patients needed surgical exploration and obtaining of pathology specimens. And then 17% had biopsies established from outside the GIT, 13% genetic and other lab testing, 13% a deeper analysis of the patient history. And I quite like this. I think it's important that whenever we are faced with a diagnostic dilemma, we always need to go back to the history and review the history, because that's often important. And then there's smaller percentages for additional imaging and endoscopic evaluation. So what are some of the most common mimics that are misdiagnosed as IBD? So this is a colorful slide, but it's also a busy slide. And one of the things to note is that the list of differentials is very long. And if you look at other texts, it's probably even longer than this. But there are one or two things I just want to point out. So for example, there's an initial categorization of the mimics into the infectious and the non-infectious group. And I imagine that in our part of the world will be really keen on the infectious side of things. And then on the infectious side, one can think about whether it's predominantly an ileal or an ileocolonic process. And there are organisms or infectious agents that predominate in that area. And then you've got those that predominate on the colonic side. So that may be useful as well in thinking about the differential. But they also highlight here that it's always important to rule out infection, and we'll talk a bit more about that. The non-infectious side is a whole list of things, but what I'm actually going to do in the next slide is to rearrange this and probably try and put it in a way which I consider is important or relevant to our particular setting. And by important, I'm not referring to the actual disease process, but just the fact that it's relevant to our context. So this is what I consider is a useful list to think about. TB goes without saying on the infectious side, HIV-related, chronic GI infections, atypical mycobacteria, Clostridium difficile, probably under-recognized. Part of the challenge is that, the testing modalities are not widely available. We see a lot of amoebiasis, and that's important, as well as the other infectious agents. So I put down at the bottom there other bacteria, which for the most part are actually there are GI infections, but often they present acutely, and a lot of the times one can exclude them on the basis of, the history or the acute presentation. On the non-infectious side, irritable bowel syndrome, and is an interesting condition because it is also, somewhat like IBD, a diagnosis of exclusion. But we often see these patients coming in with chronic symptoms, and then you scope them, and maybe they've got a few aphthous ulcers in the colon or the terminal ileum, and you're wondering whether, in fact, it represents an IBD process. Then, drugs, sometimes they're often under appreciated, particularly NSAIDs. And then you've got your MMF, as well as the immunotherapy, immune checkpoint inhibitors. And where these are used, they're actually very important. Sometimes the patient has got a cancer, and in the right patient, you want to be thinking about ischemia or segmental colitis associated with diverticulosis, as well as the systemic vasculitis. So just proceeding with the mimics, I think the entity of proctitis or perianal disease does present a unique challenge in patients as to whether they've got perianal Crohn's disease or they've got something else that's causing that. And I think it deserves specific mention in terms of the particular differentials. Now, these might apply in other contexts, but I think these are conditions that one wants to think about specifically in this context, particularly your sexually transmitted infections. And hidradenitis is important. Mimics perianal Crohn's disease quite a lot. The challenge is that patients with IBD, the prevalence of hidradenitis is actually much more common. So it is sometimes considered an extraintestinal manifestation. So you don't know whether the fact that the patient with hidradenitis actually means they've got IBD as well. So let's not forget the solitary rectal ulcer syndrome. We see a lot of radiation-induced injury in patients who have got treatment for cervical cancer, and then mucosal prolapse as well. And then these are what I consider the less common of the rare entities, so sarcoidosis. I am reminded of the trauma that I experienced when in my exam. Jill Watermeyer asked us to write short notes on IBD manifestation. GIT manifestations of sarcoidosis, but it's actually a relatively rare entity. And then the other thing, so we can probably add to that list. So these are just some pictures of endoscopic images where the diagnosis was in fact not IBD, but various mimics, and we have got the reference there. So amoebic colitis, vasculitis, Behçet's. This was a picture of ischemic colitis, and then some ulcers related to non-steroidal use, immune checkpoint inhibitor colitis, and then the distinctive appearance of radiation-induced injury, diversion colitis, as well as colitis associated with diverticulosis. This is just almost a summary of some selected pathologies and to what extent they may mimic IBD in terms of the clinical features as well as the pathological features. So, and you can see top of the list, conditions like IBD and amoebic colitis, as well as your sexually transmitted infections, which are probably important in our context, and the fact that they can mimic IBD quite significantly. And then the list goes on until you get to the bottom where you've got the relatively the conditions that probably will not mimic IBD to a greater extent, and that includes your drugs like your NSAIDs and MMF, sarcoidosis, and the presence of a mass lesion. So I'm just going to summarize and highlight the fact that if local research data would be useful in guiding practice. For now, anecdotal evidence is that we have a lot of infectious disease, and chances are that a lot of our mimics are infectious disease. But if we actually have data, it can inform to what extent we diagnose mimics, or mimics are diagnosed, and what are the specific mimics. Peculiar aspects of the history may be important to establish. I did talk about gravitating back to the history where there's a lot of uncertainty. So we need to make sure we've established the HIV status of the patient, sexual history. Travel is often in the context of patients traveling from Europe and so on to coming to Africa. But even in our context, a patient might travel from Johannesburg and be camping in the bush for 2 weeks and then, before going back. Pre-existing or coexisting diagnosis, which I call the company it keeps. I think that's important. If you have a patient that's presenting with chronic GI symptoms and they been on treatment with immune checkpoint inhibitors, for example, they have a pre-existing diagnosis of or radiation treatment, or possibly they risk factors for ischemic colitis. These are patients where one would not jump to make a diagnosis of IBD, because often the pre-existing or coexisting diagnosis explains the problem. We must do an active search or exclusion, possibly even initial treatment for infectious agents. And that's important before we make the diagnosis. Sometimes special investigations may be required for the diagnosis. And nowadays we have PCR-based or nucleic acid amplification tests for most infectious diseases, which we can apply on the stool samples or on biopsy samples to try and make a diagnosis of infectious disease. And then much like the IBD series, IBD Live series, I think that's an important idea that we should have a periodic review of IBD diagnosis, especially where the treatment response is suboptimal, or in those patients where we were not entirely confident in the diagnosis. So this is much like time will tell. And I think that happens a lot with IBD, where the condition may be evolving, and with time it becomes clearer what the ultimate diagnosis is. So thank you. That's the end of my talk. I'm going to stop screen sharing.
Thanks, Tendai. That was a fantastic overview. And I'm really sorry about the post-traumatic stress disorder from the sarcoidosis question in your exam. Thanks, Leo. If you could share.
Too little, too late, Jill.
Evil, hey.
Okay. Good afternoon, everyone. What I decided to do is to just put Tendai's talk into context. And what I'm going to do is to go through a number of cases that I've seen over the years, some IBD, some not IBD. I do work at Parenyatwa Hospital, which is also in Harare, and I also do a little bit of private practice. So the cases are going to be a mixture of cases from across the range of Zimbabwe within both the private sector and the public sector, and they all come with their own peculiarities. So the first case that I'm going to present, very short, 19-year-old female patient that I saw some years back. We had been having episodic crampy abdominal pain since the age of 8, and had had numerous emergency room visits, and now was being managed by gynecologists as chronic pelvic pain. She had a microcytic anemia with a thrombocytosis and a very high CRP, and at colonoscopy she had a stenosed IC valve with inflammation in the distal terminal ileum, and this was clearly a case of Crohn's disease, managed initially with steroids and azathioprine, but because she had limited disease, we ended up offering her surgery, and she is now at university. So fairly straightforward Crohn's, limited Crohn's ileitis, and with good response to management. Second case, a 42-year-old man that I saw initially in 2017, actually. And when he came in, he had been having intermittent bloody diarrhea associated with a backache since 2014. And over those 3 years, he had been repeatedly treated with courses of metronidazole. I don't know whether that had to do with the fact that his wife was a nurse. He was a non-smoker, and when I examined him, then he had a tachycardia of 110 beats per minute, CRP of 65, and had iron deficiency anemia, and managed him as a case of acute severe ulcerative colitis. As you can see, that's his colon up on the right upper side. He still gets some frequent flares from time to time, mainly because of that we haven't been able to get him off onto more effective treatments beyond azathioprine. And this clearly ulcerative colitis, I haven't had any doubt. Case number 3, 46-year-old woman. I saw her several years ago. She was a non-smoker, came in with intermittent watery diarrhea for nearly 2 years. And she also had pain on passing stool and had a perianal discharge. Over the course of these 2 years, she would have oral and perioral ulcerations that would come and go. And she had pain in the small joints of her hands, wrists, elbows, shoulders, and knees. And occasionally, these joints would swell up. When I examined her, she weighed 64 kgs, BMI 25. She had koilonychia, a hypopigmented rash on her hands and limbs, and she had oral aphthous ulcers, and she had quite tender wrists with evidence of synovitis. She had an HP of 10.5, a thrombocytosis. Her CRP was 101, and she had an ESR of 87 with a normal chest X-ray. So at colonoscopy, she had a normal terminal ileum with transverse ulcerations in the ascending colon and in the cecum. Histology came back showing a heavy chronic inflammatory infiltrate with distorted crypt architecture, cryptitis, but no granulomas. The question that then come up is whether this is Crohn's disease with joint manifestations. Despite this, we started her on TB treatment. This was on the 30th of April 2021. And when she came back in July, her diarrhea and perianal symptoms had completely settled. She was very happy. The joint pain was also settling. Her CRP was had come down. She had new onset numbness, which were attributed to the TB medications that she started. So this is a case of intestinal TB mimicking Crohn's disease, and it's something that I think we all see from time to time across our across the region. Then case number 4. This was a 49-year-old man. He was referred to me because he was a workshop manager at a mine down in the Zambezi escarpment. He worked for a very good company that when they brought him, they actually wanted to send him off to Joburg to be seen because they said this man must have the best of care. He was a non-smoker. He had diarrhea for nearly a month with painful oral ulcers. He had night sweats, had lost a little bit of weight. And when I saw him, he had a low-grade fever and oral aphthous ulceration. His CRP was 142, HB normal 14.6, and a platelet count of 450. When he came, he had a CT scan that reported a diffuse bowel thickening marked in the cecum and the ascending colon, normal transverse colon and some thickening in the descending colon with pericolonic fat stranding. He had actually been referred as a case of suspected Crohn's disease. And at colonoscopy, again, he had these sort of ulcerations. And the debate was what to do with him. His histology just reported a mixed acute and chronic inflammatory infiltrate. Not much of the comments that we would want, and no granulomas. I dragged this patient kicking and screaming to say, look, I think you need TB treatment rather than Crohn's disease. He didn't agree with me, but nonetheless took the medications. His urinary lump, which is not a test I would do very often in this patient, in such a patient, came back positive. And we started him on TB treatment. He then mentioned, oh, by the way, my driver, when I'm at the mine, there's a guy who drives me around. It has been coughing for quite a lot and is now on TB treatment. We persevered with the TB treatment in this patient with clinical improvement and biochemical improvement. And 2 weeks later, what he really had were the ulcers had resolved, and he had just some pseudopolyps forming. So again, this is a case of intestinal TB mimicking Crohn's disease. And the difficulty in this patient was that his demographics and lifestyle was such that you were going to tend more to go towards inflammatory bowel disease than TB. Then case number 5, these patients that I'm presenting, some of them, you'd see them for the first time when they are sent for a colonoscopy, and some you'd actually have seen them from the start. This is one of the patients who was sent to me for a colonoscopy, 42-year-old woman who had been having abdominal pain and constipation. And at colonoscopy, what she actually had was ulceration in the terminal ileum. And when you talked to her, when you went back and got a history, you realized that she had a bit of malaise followed by fevers over the preceding week, and had swinging fevers with a pulse ranging from 50 to 60. So that's classical of the pulse temperature discrepancy that you get with typhoid. And we said, let's treat her as typhoid whilst waiting for microbiology, and she improved. And what I actually decided to look up is to say how many typhoid fever reports have been reported across Africa over time. And what you actually see is there have been reports from virtually everywhere, except very, very few countries in this systematic review. And I think what's important to also realize is that people are now much more mobile. So you may be sitting in Lusaka, Zambia, or in Nairobi, but if there's a disease that's been prevalent 2-3 countries away, it may very well knock on your door. So typhoid, remember, it's caused by Salmonella typhi, and it is a disease of many faces. But in terms of the GI, patients very often have constipation more than diarrhea, but sometimes they can develop diarrhea. They can come in with vomiting, and the complications vary from GI bleeding. They may eventually develop intestinal perforation, which may happen with the terminal ileal ulceration that the case that I've presented had. And they also get a hepatitis, and sometimes may present with E. coli cystitis. So case number 6, somewhat similar to this patient that I've presented. This is a 23-year-old university student who was at university in Bulawayo. Bulawayo is the second largest city in Zimbabwe. And when he came from Bulawayo, he actually went to visit his mother. His parents were separated. So he went to visit his mother in Mbare, which is impoverished area of Harare. And after that, his father lived in another part of the city that had much better sanitation. And that's where he went after that. And whilst he was there, he started developing a watery diarrhea with intermittent fevers, was sent to one of the private hospitals in the which is in a rather expensive place where one wasn't expecting to find someone with diarrhea and this sort of fever. And he had been on multiple antibiotics when I was asked to see him without any change. And he continued to have fevers together with diarrhea. Blood cultures had been negative twice. He was HIV negative. These two examinations just showed scanty red blood cells and culture was negative. His ALT was 89, AST 204, just a slight transaminitis. And the thought that I actually had when I saw him was, are we dealing with typhoid, which is what we have seen previously. So took him for a colonoscopy. He had just a little bit of terminal ileitis, and he had a gaping IC valve, and he had transverse ulcers in the ascending colon and in the cecum and in the proximal colon. So my thought then was, let's treat this patient for TB. His histology did come showing cryptitis with crypt destruction and crypt abscesses with no granulomas. But the interesting thing is, whilst waiting for the TB medicines to come, because what happens in our setting is when you start someone on TB drugs, they have to get them from 2 specific infectious diseases hospitals. So he took 2 days for the medicines to come for one reason or the other, which was fortunate for him. Because whilst we're waiting for this, he completely settled on intravenous metronidazole. When I reviewed the charts that the doctors who were looking after him were using, I realized that they had actually never used metronidazole on him. And maybe serology came back positive weeks later. By then he had been discharged and had gone home. Case number 7, a 30-year-old woman who came with for a colonoscopy with long-standing abdominal pain and occasional diarrhea. She grew up in Muzarabani, which, if there's anyone who would understand Shona, it's literally means it's a place full of water. There are floodplains there. And at colonoscopy, she had just loss of vascular markings in the rectum, so she had a proctitis. But her histology came back showing this. This is a picture of the egg that's there. You can barely make it down there, but just an oval-shaped egg with a lateral spine of schistosoma mansoni. So this is a patient who had schistosomiasis, mimicking, looking like a proctitis when you saw it initially. Case number 8, which should be towards the last of these cases, 34-year-old woman came for a colonoscopy with rectal bleeding and clots and had associated lower abdominal pain. And on examination, had left flank tenderness. The HB was 9.6 with an MCV of 78.2. So colonoscopy, she had this almost serpiginous ulceration in her rectum, quite deep and circumferential, which I wasn't too clear about until I took a history. And the history was of someone who I'd seen about 2 weeks earlier with these angioectatic spots that I've demonstrated. This is of a different patient. And she then mentioned to me that she had cervical cancer some 5 years earlier and was managed with chemoradiation followed by brachytherapy. So this was a particularly severe form of radiation proctitis. Whilst Tendai was speaking, I just decided to put up a last case of a patient that I've seen who had mucosal thickening and a proctitis of this nature. And it turned out that he actually had bladder cell carcinoma that was invading into the rectum and mimicking a proctitis. I think that about sums up what we see, the IBD mimics that we see. And when IBD is not as common, it becomes even more important to be very much aware that there are many things that can look like it. And the 5 key takeaways that I wanted to put across, mainly just emphasizing what my colleague presented, is that it's extremely important to know your own local disease epidemiology. And whilst you know it, you must actually help in publishing and increasing the body of knowledge in your own local setting. It is also important to know what's happening around in the region, because people are traveling a lot these days. Then it is important to take a good history. That's absolutely important. Then thirdly, you must develop a good relationship with your pathologist, and one needs to know what to actually ask to be able to get good answers. Number 4, when in doubt, err on the side of empirical antimicrobial therapy. I think it's safer. Then 5th, trust your instincts. I think after a while, you get to know what is IBD and what is not IBD. And sometimes it's actually difficult to explain to people why you think this is IBD and the next patient is not IBD. Thank you very much. I think we can discuss.
Thank you, Leo, for sharing those incredibly interesting cases. And I must say, both of you guys gave the most amazing presentation. So thank you very, very much. So I'm going to kick off with the first question for Tendai. This is from Akwi Asimbang, and she's asking, would you be a little bit more sort of specific about which mimics we should really worry about in Africa? Because obviously some of them are more pertinent to the West or more first world countries.
Thank you. Thank you, Jill, and thank you for the question. So I think I probably showed a slide. Obviously, there's lots more, lots of cases that one would probably be worried about. But obviously, we are very much concerned about the infectious disease mimics that we see locally. So TB is always, a main consideration or top of the list, and sometimes can be very difficult to tell apart. We did have quite a comprehensive discussion on the distinction between TB and infectious and IBD at our last meeting. And sometimes a trial of treatment is warranted. But I consider TB, maybe colitis, we see that quite a lot. I think Leo has also shown that. And also the kind of acute or subacute bacterial infections, enterocolitis, I think those are important to be able to think about. So I think upfront, I would say one must actively screen for all the infectious or most of the infectious etiologies. And as Leo said, consider even empiric short course antibiotic treatment before considering the non-infectious etiologies.
Yeah, absolutely. And Tendai, I mean, my impression is that very few countries in sub-Saharan Africa will have actually access to something like PCR to diagnose infections. Any comments on that?
Yeah, no, I totally agree. It's not, those are not sort of tests that are widely available, particularly in state institutions. And that does obviously put, a hurdle in terms of our ability to accurately diagnose whether it's IBD or the IBD mimics. So I think it just represents one of the main challenges that we have in terms of making this diagnosis.
Yeah, absolutely. Leo, can I ask you, have you ever seen strongyloidiasis?
Yes, but I tend to see, I've never seen it with frank colitis, but it's something that's very well described, and it becomes even more important to be aware of it because you can get a hyperinfection syndrome if you start patients on steroids. So it's something to be very much aware of. Actually, I think one of the things to think about I always look at eosinophil count. I know you can get an eosinophilia with IBD, but I think if you see eosinophilia, you really need to think of the parasites.
Yeah, absolutely. So I've seen two cases, and if you give them steroids, it's invariably fatal, actually. So it's something to really think about, and it presents like an acute severe ulcerative colitis. So always think about it, especially if you've got people who are coming from an endemic region. It's not endemic in South Africa, but we have a lot of people coming from north, so it is something in our differential. And then just another comment, I don't think you really mentioned it, Leo, but amoebiasis, I've seen quite a few cases of it being sexually transmitted. So it is in the differential diagnosis of a sexually transmitted proctitis. Okay, and then just two questions from Akwi. The one is about rescoping after you've given TB treatment. When would you rescope?
That's an interesting question, actually. I would rescope for after 2 months, but I'm not too fast up about that. It really depends with what is available to you. Are you going to put your resources into rescoping someone who is now completely fine? So I think, yes, one would say I would rescope, but only when I'm still not clear and the patient is still sick. I think you must use your clinical judgment on that.
Yeah, I absolutely agree. Okay, so two more questions from Akwi. And both you or Leo, either of you can answer them. What happens if you've got one of these infections and you give a patient steroids or a biologic?
And
Okay,
would you want to take that?
Yeah, I mean it's obviously an undesirable situation. You really run the risk of perpetuating or worsening the infectious process, so hastening the patient's deterioration from the infection. So essentially, if they've got active TB and you immunosuppress them, they are unlikely to get better, and they will probably get worse and keep getting worse. So that's important to be aware of, yeah.
And then another question, I think this one's for you, Leo, as the king of colorectal cancer. When would you start screening for colorectal cancer? 8 years after diagnosis, or would there be other factors that would make you want to screen earlier? I'm assuming this is ulcerative colitis we're talking about, specifically, or extensive Crohn's colitis.
I think the most important thing is to think about, because there's a lot of delay to diagnosis in our patients. Sometimes some patients I've had patients who have been symptomatic for 10 years. So such patients, you may have to start screening right from the diagnosis. The only good thing is a whole lot of our patients tend to have UC limited to the rectum, really just mild ulcerative proctitis. So it's not as big an issue as elsewhere. But I think all in all, one just has to follow the international guidelines.
And of course, scope earlier if there's PSC or positive family history.
Yeah.
And then this is actually just for my interest, because obviously in state practice, nobody gets to use immune checkpoint inhibitors. It's just, yeah, they're just too expensive. So Chris, I don't know if there's anybody else from the private sector. Akwi, you might have experience. How many cases have you seen of immune checkpoint inhibitor colitis, or have you seen any? Chris,
Sorry,
you
Jill,
muted.
I missed it. How many
Okay.
cases
All right.
of?
Yeah. Have you seen any immune checkpoint inhibitor colitides? We don't see them in state.
We saw a couple in the early phases. Yeah, a couple of young people treated with myeloma. And we ended up giving a biologic infliximab for them, and they did very well. But I think I'm not sure. I'm not seeing so many. I thought I would see much more with the advent of, with more usage. Maybe they're not just coming my way.
Yeah. Okay, so this is another question from Akui. I'll take this one. In your UC patients, how often do you find PSC, or do patients with PSC present with UC? Okay, so across the board, we have about 8% of IBD patients will present with primary sclerosing cholangitis. This is obviously much more common with ulcerative colitis than it is with Crohn's colitis, but we do see it with Crohn's. But on the other side, the vast majority of patients who have PSC will actually have some form of IBD. And you can get the PSC predating the IBD, or obviously coming after the IBD. So we are very aware of it, because it obviously changes your screening protocol significantly, and patients will require a yearly colonoscopy for surveillance. I hope that answers that question. Any other questions from anybody? Just trying to think of anything else. Anybody have any questions? Yes, Akui, yes. I do believe that we should screen PSC patients for IBD, at least by doing a fecal pulp detection or something like that. Chris, what would your feeling be about that?
Yeah, I agree. Absolutely. I have a question, if I could give you a contrasting experience, and I would like to echo Jill's sentiments. Thank you, Tendai, and Leo, absolutely outstanding. So in an urban South African setting where infectious diseases are not foremost on your mind, but yes, we are mindful of TB and others, I have in my career been faced with an isolated terminal ileitis with imaging, which shows either inflammation and or narrowing, and where your biopsies come back negative. The differential is a little different to if you incorporate the colon. So what would your management be there? I mean, I like using steroids in my setting where infections aren't really foremost in our mind. And as long as it's a short course of steroids, I mean, I wouldn't even give more than 5 days. You know, the issue of giving steroids and worsening an underlying infection is if you continue, you know, week after week. But if you use a short course of steroids, fairly high dose, and judge clinical response, it kind of gives you an approach on what you're dealing with. Your thoughts on that?
So yes, Chris, I mean, I do agree with you, but just remember that lots of infections get better on steroids. So, you know, it can be a little bit confusing, but I agree, you're probably not going to do any harm if you give a little short course. It's certainly not going to make things go completely crazy.
So if you do get a response, I mean, yeah, I mean, the point is, in the back of your mind, and the clinical approach is, you know, I mean, you do think it's inflammable, and I like Leo, you know, trust your gut feel. I mean, I think that in medicine often do all the tests, but at the end of the day, there's no one test that's going to tell you exactly what to do. No. And in this scenario, you kind of trust your gut feel, but you feel insecure continuing this inflamed bowel route, this Crohn's route, if you know, just not having histological proof and just having this kind of steroid response. So it becomes a little bit of a dilemma when you get small bowel disease, Crohn's disease, that you can't biopsy prove.
Absolutely. And that's where, of course, for Crohn's disease, short segment ileal disease, surgery upfront is an absolutely superb option, because patients, provided they stop smoking, they can be disease-free off any medication for 10 years. So not only do you give them a very good therapeutic option, but you get what we call the big biopsy, which will tell you exactly what is going on.
Jill, your concern, your differential in that sort of terminal ileitis, TB, Crohn, inflamed bowel, lymphoma, certain drugs, I think, can give it to you, isolated, vasculitides. I mean, so I'm just contrasting the setting that we see as opposed to what you see, Leo and Tendai.
Sure.
Yeah, and it's quite interesting because Jill always used to talk of a giant biopsy. That surgery is a giant biopsy, and
and
sometimes
it's still an excellent
terminal ileal
option.
disease.
Yeah,
Yeah.
it's an excellent option. It really is.
So what
And
do you
this
mean
has
by
been
giant
shown-
biopsy?
Terminal ileal resection of short segment ileal disease.
Yeah.
Okay.
Big
I was
biopsy.
planning on ordering new biopsy sets.
No, we know from the Lyric study, which was a comparison of laparoscopic ileocecal resection for ileal Crohn's disease versus infliximab, that surgery gives you a fantastic quality of life, and it actually works better than surgery, at least up to 5 years. So I'm very much in favor of that, especially if you're worried about pathology that you've misdiagnosed. But I think we're about out of time. Any other pressing questions, comments? In that case, I'm going to thank Leo and Tendai for absolutely fantastic presentations. It was really nice to have some people from outside of South Africa present their data and their perspective on things. Also, thanks, Akwi. Very nice to have lots of questions. We love that. I hope you're going to join us every time. And then also thanks to iEcho University of New Mexico and the iEcho India team. The recordings, as usual, will be available on the Gastro Foundation website. Of course, thanks to the Gastro Foundation of Chris for all his amazing support of continuing medication. Thanks to our sponsors. And of course, next week, the topic is pathology. So with that, have a good evening, everybody, and hope to see you all next time.
Thanks a lot. Thanks,
Cheers.
everyone.
Thanks,
Thanks, Leo,
everyone. Bye.
Tendai. Nice to see you.
Bye.
Cheers.